Hi, everybody. This is Kara Fitzgerald at New Frontiers in Functional Medicine. I would not be here month in and month out for the past 6 years without the generous support of our sponsors. And I want to tell you about them. And please check out their websites and check their products out. Biotics research. For over 40 years, the foundation of biotics research has been innovation and quality. Their goals remain unchanged: innovative ideas, carefully researched concepts, and product development with advanced analytical and manufacturing techniques. Biotics nutritional products are of superior quality and effectiveness and available exclusively to healthcare professionals. Visit them at bioticsresearch.com. Integrative therapeutics. Integrative therapeutics is focused on inspiring a better lifestyle through better health. By providing meticulously formulated nutritional supplements and valuable resources, Integrative Therapeutics promises to enrich your patients and embolden your practice. Welcome to your Integrative Therapeutics. Find them at integrativepro.com. And finally, I want to give a shout out to my friends over at Rupa Health. They make lab testing easy, fabulous, doable for both you, the clinician, and you, the person being prescribed the lab, the patient. Consider using Rupa as just a super smart solution to all your laboratory needs. Visit them at rupahealth.com. Hi, everybody. Welcome to New Frontiers in Functional Medicine, where we are interviewing the best minds in functional medicine. And today I have one of the very best and one of my first podcasts. This is Dr. Keith McCormick, and we talked back in 2015. Let me give you his background and why I'm absolutely honored and thrilled and excited to have him with me today. Dr. McCormick is a board-certified chiropractic physician in the states of Massachusetts, Colorado, and California. He's been in clinical practice since 1982. He earned his bachelor's from Stanford and his doctorate from the National College of Chiropractic. He is an instrument-rated commercial pilot and a U.S. Army veteran. Sports have always been a big part of his life. At Stanford, he competed on the varsity cross-country and fencing teams. As a junior, he was the silver medalist in the 1973 Modern Pentathlon World Championships. He competed and succeeded in a whole lot of other events, but really one of the crowning moments, I think, actually you're continuing to compete, Dr. McCormick, but he was in the 1976 Olympics in Montreal. He was part of the modern pentathlon team, and he is also a former U.S. record holder, the most points scored in a pentathlon competition. Dr. McCormick continues to compete in triathlons of all distances and has completed 6 Ironman competitions, 5 of them after recovering from multiple osteoporosis-related fractures. I want to add to this bio before I welcome you. It was this journey. I know this about Keith. Keith is a friend of mine, and as I said, we've podcasted before. This incredible sports journey that continues to be a huge part of his life, that brought him to his own experience with severe osteoporosis, and maybe we'll touch on that a little bit, but focused his career, and he's the leading, I'm not even going to say he's the leading physician in the functional integrative space and really beyond, thinking about osteoporosis through a systems lens, through a systems functional lens. His first book was this slim volume, A Whole Body Approach to Osteoporosis. I pulled it off my shelf. It's dog-eared. I've folded tabs, I've highlighted it, I've got notes in here. I use this in clinical practice. I've recommended it to other physicians over the years, many times, and I've recommended it to patients for years. He recently updated it with this 700-page volume that is a must for us as providers. This has got to be sitting on our shelves. This will become dog-eared in my practice as just a brilliant update on this book. And it's also written in plain language. So this is something that, regular folks who have osteoporosis or have some kind of a bone loss issue or are working, have a loved one with it, this is a book that they can access and use as well. So I value your friendship. I just value your brilliance, your commitment to the science. I mean, we go back to when I was in my postdoc in the lab, so many years we go back. Welcome.
We met in Georgia 20 years ago or something.
A long time ago. Welcome once again, Dr. McCormick, to New Frontiers in Functional Medicine.
Thanks for having me, Kara. Appreciate it.
So, yeah, absolutely. We're going to dive into all your thinking on bone loss and how we want to work with it as clinicians. But I just tell me a little bit about your story, your incredible story, and you continue to compete as intensely. And you just mentioned to me earlier that you're 69 and, clearly so healthy, but you resolved your own osteoporosis. But tell me a little bit, and then we'll just jump into the book.
Well, I've been running and swimming and doing everything since I was 5 years old. That's been my life is athletics. And when I turned 45, I started breaking, had like 12 fractures in 5 years, and I've had probably 22 fractures in my life, something like that. And so I went to several endocrinologists, 5 of them to be exact, and they just wanted to put me on drugs. And I said, no, I can't do that. Just got to figure this out. And I said, I'm 45 years old. Am I supposed to, I'm going to live to 90? Am I going to take drugs for 45 years? It didn't make sense to me. So I knew I just had to totally immerse myself in figuring this thing out. And that's what I did. I just plunged into it headlong and figured out a lot of things and wrote these 2 books. And yep, I'm still competing and I don't fracture. And people can do a lot more than they think they can. And that's why I wrote Great Bones, the new book, the way I did. I wanted it to bridge this gap between the public, the layperson, and the doctor, because doctors need to know a little bit more about this disorder, and the layperson needs to know how to interact with their doctor. Number one. Number 2, how to even understand the complexity of this thing. And yes, the book's a little complex in certain places, and you have to wade through it and pick things out and maybe not read certain things if it's too complex. But I think what it does is arm the patient with a way to communicate better with their physician.
Well, and it arms the physician with an approach to osteoporosis. I mean, there's just no question about it. I'll use it in my practice, just as I used your original volume, which was, a quarter of the size, but still very smartly written, very actionable. You're not anti-medication, and we'll talk about that. But before we do, who's at risk for osteoporosis and what are the risk factors?
Everyone. There's all these risk factors that doctors usually have in their head, underweight, female, people who take medications, there's lots of risk.
Non-athletes, sedentary. So you blew all those up.
That's right. So, but I had osteoporosis and I never took a drug. I was an athlete all my life. I drank milk out the wazoo. I mean, I was hooked on milk. I did everything right and I still got it. So I don't even pay attention to risk factors. Everybody should be assessed for bone loss, and bone density exams aren't perfect, but they're sure worth doing. And they're non-invasive, they're cheap, they're simple to do. Everybody should have a bone density, at least by the time they're 50, 55 years old.
Okay, all of us by 55 at the latest, 50. Does family history flag? Yeah, go ahead.
You find out you have low bone density, the more you can do about it. If you don't find out till you're 70 or 80, it's a lot harder to gain it back. If you find out when you're 45, like I did, it was great. I still had time to improve upon. I wish I would have known a lot more. It took me 5 years to get up and running because I had to educate myself. But it would have been better for me to find out at 40.
Sure. Or in your case, you probably were showing up with bone loss even earlier if you fractured.
I'm sure I was.
At 45.
The reason why is because, number one, I was gluten sensitive. I'm not celiac, but also I just trained really, really hard. And I was low weight and probably didn't get enough protein. And I trained, when I was training really hard, I trained probably 14 to 16 hours a day. I mean, it was all day long for years and years and years. That was my professional athlete. So it when you do that, you're totally immersing yourself it does build up a lot of oxidative stress, a lot of increase in pro-inflammatory cytokines. And I'm sure that fueled my osteoclast to break down bone.
Right. But I do want to point out, as you and I were just talking about offline, that you're still engaging in Ironman triathlons. You're still doing it. You're still out there. You said you just came from a half marathon and then, or a half Ironman, and then you went and did a marathon 6 days later. You just told me that. So you are working out like, way on the other side of the bell curve, but you're fine now and you're healthy. You're just doing it smart. You're
Yes,
great.
I'm smart, but I'm doing it
Yeah.
smart. Totally different than what I used to do. Yeah.
That's another conversation, as I said to you then, but I would just love to understand how you're doing it, how you're doing very intense athletics on the, almost 70 with, such vibrant health. It's awesome. And your bones are intact and strong. And it's very inspirational for me. And I know it will be for other people as well. It's so cool. I mean, we have this, I think, inappropriate belief that doing, intense athletics, doing ultra athletics can be damaging, and in a certain population, or doing them inappropriately, as you were early on in your career, is damaging. But you figured out how to do it right, and someone's got to mine that gold. Maybe it will be me. All right. So what are the best diagnostic imaging tools for bone health, bone status?
There are so many laboratory tests that are they don't even, I think there's so many that we don't even realize how many we have available to us. So
Okay.
number one, everybody has the bone density,
Yep.
and that's so bone strength is a combination of density and quality, and a bone density exam only does bone density. So there's bone quality too. 50% of the bone strength is quality, and we don't even know what that is. I have patients that are negative 3.0 and they break, and I have others that are negative 4.5 and they don't break.
And they don't. Yeah. So define that. So how do we figure it out?
Well, there's a few ways. The trabecular bone score is a good way to go, but that's only one little aspect of quality, and that's trabecular connectivity. So the TBS, or trabecular bone score, there's not very many of them available, and it's not a test. It's a computer add-on to a DEXA. So there's only, like in Massachusetts where I am, there's only like 10 or 12 of them, but you have to call up the hospital and talk to radiology and say, hey, does your DEXA have TBS capability? So what they do is they just analyze the bone density results with a computer, and they're looking at the grayscale, the pixel grayscale of the trabecula to see if they're connected. So if you have disconnected trabecula, it's degraded. It's a degraded quality of bone, which increases your fracture risk. So that's probably the number one way to look at quality. Number two is certain labs. And that is, I use a lot of bone turnover labs. The main bone resorption lab test I use is C-telopeptide. You can also use N-telopeptide. It's just the N-telopeptide, C-telopeptide are similar in that they're just opposite ends of the collagen molecule that you're testing for. And when that number is high, that says the osteoclasts are hyperaggressive and breaking down too much bone. And we get a lot of bone collagen then running around in our blood. Or if they do, a person can do an NTX, N-telopeptide, and that's either urine or blood. But in order of accuracy, I would say the spot urine NTX is the worst. The 24-hour urine NTX is a little bit better. The serum NTX is better, much better. And then the blood CTX is the best. And that's what I use.
Awesome. And that's available. I mean, that's available through our standard insurance covered. Yeah, from Quest. Yeah.
There's a CTX. And then for bone formation, I use P1NP. I used to use osteocalcin, but that's a really squirrely test and doesn't not that accurate. It's really affected by food and time of day and stuff. I mean, so is CTX. So let me say one thing about CTX.
Yeah.
And the reason why a lot of physicians don't use these turnover markers is because they're frustrating, because you have to do them exactly right. So the CTX, the only way you're going to get accurate results is the patient needs to be fasting. They need to go to the lab first thing in the morning, because if there's a huge difference between 7 o'clock and even 11 o'clock. It just really decreases in its levels throughout the day. It's high to 3 in the morning. It's the lowest in 3 in the afternoon.
Interesting.
And then no biotin and no collagen for 48 hours before.
Good.
So,
I was going to ask you about collagen, but biotin also. It's one of those labs that just is influenced negatively by biotin.
and then for P1NP, which is called procollagen type 1 N-terminal propeptide, it is much better than osteocalcin for bone formation, so osteoblastic activity. And I use that not on every patient. I use CTX on every patient. But the reason why I use P1NP is let's say if a person is going to do a anabolic drug such as Forteo or Timlos or Somozob, you want to make sure that these drugs are working. 5% of the time they don't work. So it'd be silly to do teriparatide, which is Forteo, for 2 years. The person's injecting themselves every day, and then 2 years later you find out, whoops, it didn't work.
Wrong drug.
So
So how do you figure that out?
So you make sure you get a baseline P1NP. 3 months into it, you do a repeat P1NP, and it should be up a lot. So if they had a baseline 40 for a P1NP, it should be up to at least a 60 or 70.
That's
And
awesome.
if it's not, then you know it's not working. You got to switch to something else. Then I continue to do, especially at 18 months, I do that P1NP again, because if it's back down to 40, I know that the teriparatide isn't working anymore. And that happens. It loses its oomph after about 18 months. If it's still up, if the P1P is still high, then continue for the full 2 years.
Okay. I want to just ask you a couple of questions on that. That's so helpful. Is there an optimal reference range for either of these, or are you relying on the lab ranges? Are those comfortable for you?
Don't rely on the lab ranges. They're terrible. So
Okay.
example, peptide, I think it's between 36 and 136 or 1,036, something crazy like that. So no, a good reference range for CTX is between 300 and 400, 250 and 400. So I start losing bone at around 350 CTX. If a person's on a medication that like a bisphosphonate or Prolia, that will bring it down to 100, maybe 50, even below 50, which I don't like. But you can, because a lot of these drugs can oversuppress the osteoclast, and that causes other issues. So I watch their CTX, I watch their bone-specific alkaline phosphatase for oversuppression, and but yeah, you have to keep doing these markers to see what's happening. As the drugs can work, they can work too much. Another example, and I hope, sorry to keep getting
No, go.
Talking
This is really helpful
about the medications, but like for Prolia, Prolia has issues in that it's good in building bone density and bone quality, but if it works too much, if it works too well, then when you stop, it's very difficult to not have a rebound in bone loss. And so I usually don't recommend that people take Prolia for more than, so Prolia is what's called a rankle inhibitor, so a receptor activator for nuclear factor kappa B inhibitor. It's an antibody against that, and rankle is a direct stimulator of the osteoclast. So if it's an inhibitor, you directly take away that inhibition, that stimulation of the osteoclast. Osteoclastic comes down. But Prolia is an injection every 6 months. So at 6 months, you need to do another injection, because there's about a 210% variability in Prolia's actions on people. In other words, some people it works for 5 months, some 6 months, some 7 months, some 8 months, some even 9 months. But if you're a 5-month person and you miss your next injection and don't get it till 7 months or 8 months, you're going to be losing bone during that time. So you really got to do it every 6 months. But if you do it too long, so Prolia has this nasty part about it where what it does is it doesn't kill the osteoclast like a bisphosphonate does. It shrinks down these osteoclasts, makes them into these osteomorphs that are just quiescent, shrunk down osteoclasts. As soon as you stop Prolia, all those osteomorphs burst out. Then we have tons and tons and tons of active osteoclasts running around, and that's why a rebound happens and you break down bone. So immediately, and the longer a person's on Prolia, the more it works, the better its response. And that's why when patients say, oh, good, I responded really well to Prolia, and I go, yeah, a little too much, because a really good response to Prolia means that there'll probably be even a worse rebound afterwards.
Wow.
And so you have to do reclass after you're done. And the longer you're on Prolia, the harder it is to stop that rebound. But you have to do reclass. And on the reclass, you, like, let's say the person did, I usually don't recommend more than 3 injections of Prolia. But after that 6 months of Prolia, you check the CTX. And this is all written in my book. It's a little complicated. But because you want to make sure that that CTX starts rising a little bit, because you have to do reclass, which is called zoledronic acid, after Prolia. Otherwise, you can't use Fosamax or Actonel because it's not strong enough to prevent that rebound. You do the reclass, but you have to make sure that there's some activity in that in the osteoclast for the reclass to be absorbed. So, but I spell that all out in the book because it is
good. Yeah,
Yeah.
it was so important though. Let's talk. All right. I'm assuring everybody listening, we're going to get to natural interventions and we're going to talk about how those affect, how we put together a good bone density protocol and, all of that and how they influence labs. I want to talk about all of that. But since we're talking about the medications, and you do think, who is a good candidate for meds and how do you stratify, what drug for a given individual?
Well, it's so important to understand that this is not about drugs. This is not about nutrition and exercise. This is about everything. And that's what you look at it is. I have so many patients that are negative 4.5, negative 5.5, negative 5 point, negative 6.0. It's like, we're not going to get away with this for just doing nutrition. It's not going to happen. So but I have other patients that are negative 2.5, negative 3.0 that are fine with just doing nutrition. Even if they have it doesn't mean they have to do a drug. There's lots of factors that go into this. And so yes, every single person is an individual and every single person has to be looked at. Or, okay, yeah, I think, it's okay to not do a medication here, or no way, they have to do a medication. But all during that time, they're doing a medication, and usually medication only or 3 years or something that we use it, and then they're off of it. But all during that 3 years, we're making them better. We're making them healthier. And then medication, then they're okay usually.
Okay, and we'll talk about all of that. And I want to hear your drugs, but I before you go into that, like, when do you if you've got fabulous trabecular strength?
That's right.
What kind of number is going to flag you for no med required? Like, how low can you go where you're not where you don't need to prescribe a med versus when are you going to use it?
There's just hundreds of variabilities right there.
Okay.
So I can't say a number, but I would say in general, if they're over a negative 3.4 and they have trabecular disconnect, they're going on a medication.
Okay. By the way, folks, in his book, Keith has a lot of case studies. So, and you actually do really, really beautiful examples. I was looking in the genetics chapter and you just outlined a few different scenarios, but there's plenty of cases so that you can see his thinking in action in the book. So when somebody requires medication, what are the ones that you're thinking about if you can influence that decision?
All these drugs, there's probably only 10 different drugs or so. There's not that many to figure out. So, but they all have different abilities and different risks and different applications. So there's 4 bisphosphonates essentially. There's Actonel and Fosamax, which are oral. They give you maybe 1 or 2% of bone density a year. Remember, just bone density, no bone quality. There's Viva, which I don't even want to talk about, abandonate, because it's terrible and it just causes people all kinds of adverse effects. So I never, ever, ever recommend that. And then reclass, which is zoledronic acid, gives you 3 to 4% a year bone density, and that's an infusion, so 1 year infusion. And I think that's great for somebody who has a high C-peptide. I can't get it down. So for example, if
Yeah.
somebody and they have a negative 3.2 and their C-peptides a 900, which is pretty high. And going back to your question about reference ranges,
Yep.
900 in the reference range that they give looks normal. Well, it's not. They're losing bone at 900 for sure. Probably I'm not going to get that 900 down to 350 with just nutrition. I'm probably not. There's just too much going on. There's genetics involved in this, and I'm not going to get it down. If they have a 500, for sure, I'm going to probably get that 500 down to 300 or 350 with just doing nutrition, which is a big deal because anything over 350, they're losing bone. So I'm taking them from losing bone to not losing bone and much healthier without doing drugs. But if they're way up at 800, 900, 1,000, we're not going to get it down. Some of the things that do bring it down pretty easily are alpha lipoic acid and acetylcysteine, berberine, getting rid of other things in their diet, making sure they're not losing calcium in their urine, making sure their pH of their bodies, better. The more acidic they are, the worse things are. So, but those are the bisphosphonates. That's the pretty simple way to go. But if the person has a lot of degradation of trabecula and they have really bad bone density, it's not the way to go. I had a patient the other day and she was a negative 4.5 degradation of her trabecula, and her physician prescribed her, I think Fosamax. And I go, whoa, that's not good enough here, Then there's Prolia. Prolia gives people about 5 or 6% of bone density a year. Like I said, it's what's called a rankle inhibitor. And it does give a little bit of bone quality. It does great on hips. It's probably my favorite. If a person has really poor hip score, if they have low bone density in their spine and okay in their hip, then a bisphosphonate's fine. But if they have low bone density in their spine and negative 3.3 and 3.4 in their hip, you got to do Prolia. That's much better. Do that for 1.5 to 2 years, then back it up with reclass. If they have a lot of degradation though, and not too bad of hips, Forteo, which is called teriparatide, and Tymlos, which is called abaloparatide, are a really good way to go. They give you 8 to 10% of bone density in 2 years or in a year and a half. And they do great at rebuilding quality trabecula. The problem is with them, they don't do great on the hip. I've even seen them decrease people's forearm because remember, when you look at somebody with a parathyroid issue or primary hyperparathyroidism, you look at their forearm and their forearm bone density is usually really low. The reason why is because parathormone attacks cortical bone. Well, even though teriparatide and abaloparatide, you're doing a daily injection, and even though the parathormone level, so this is a parathyroid analog, recombinant DNA parathyroid analog that these are, it only rises about an hour every day. For you inject it, it increases in the bloodstream for an hour, and then it's gone. So usually it stimulates the osteoblasts and stimulate the osteoclast to build up. So both osteoclastic are increased, but sometimes it lingers and now it degrades the cortical bone too, hip and in the forearm. So sometimes the Forteo and Tymlos don't do a great job in the forearm or the hips. So you got to be really careful. So
And I'm assuming you're gonna follow up with a bone density, with a DEXA and a TBS.
in a year, no doubt. Got to do that to make sure we're not screwing up something else. We're not improving the spine yet hurting the person's hips. That would be terrible.
Right.
And then the final drug I'll talk about, well, the HRT is hormone. I'm a really big estrogen proponent. I think it does so many good things that, what's called romosomazole or Evenity is the final one I'll talk about. And that is what's called a sclerostin inhibitor. It's an antibody against sclerostin. Sclerostin is produced by the osteocytes, and it produces sclerostin. Sclerostin decreases the osteoblastic activity. So romosomazole is an antibody against sclerostin. So it takes the sclerostin away, allows the osteoclast to do their job. I've seen really good results with romosomazab. It's incredibly expensive. I think like $100,000 a year. So insurance usually won't okay it unless a person has at least a negative 4.0 and multiple fractures. But it does give people 10 to 12% bone density a year in their spine, and maybe 5 or 6% in their hips. So it does a pretty good job. It's only given for a year. It's a once a month injection. You follow it up with a bisphosphonate, well, Prolia or bisphosphonate. So they're the drugs.
Okay, good. And you cover them all in the book. Here's the book, Great Bones. It's a great book. We'll link to the book and we'll link to your website. You have supplements and you have a clinic. Are you accepting referrals at the clinic?
Yeah.
I know you're busy. Are you? Okay, amazing. I've sent people your way many times. All right, so let's talk about the nutrition and the supplements again, and the lifestyle and the exercise prescription, et cetera. Let's talk about the rest of the story. Maybe, I mean, we could cover both if it's like, well, let's cover your foundational protocol, maybe with an eye towards, the individual who doesn't need meds. Let's say they're right there at the threshold. So let's say they have a pretty aggressive osteoporosis, but they're adamant that they don't want to go the med route, and you think, okay, I might be able to do this. So it's a pretty aggressive, like walk me through what that kind of protocol looks like. I know it's individualized, but I'm curious what you're doing for somebody there.
Do labs. I always do a core based set of labs. I do a CTX, C1NP if I'm thinking about drugs for the person. For sure, 24-hour urine calcium. I want to know, number one, if they're losing too much calcium, and number two, if they're getting enough calcium in their diet. This isn't about calcium. I think you kind of understand that this, osteoporosis isn't about calcium, but calcium is important.
Yeah.
They come back with a 50 on the 24-hour urine calcium, and I think, well, maybe they're just not, absorbing or getting enough in their diet.
What's an acceptable number on the 24-hour urine calcium?
I like 100 to 225, something like that.
Okay.
So for then homocysteine, it's so easy to fix on people. I don't, I get homocysteine on everybody. If it's above 12, 15, then it will increase osteoclastic activity and increase the cross-linked stiffness in the collagen fibers. So that makes for bone to be stiffer and therefore more prone to fracture. So it's a quality issue and it's easy to fix. So HSCRP, high sensitive C-reactive protein I get. You get HSCRP, you go from 1 to a 3, and that person has twice the fracture risk of anybody. Wow. So it's a big deal. It really does. Yeah. And same with homocysteine. You get up to 20 on homocysteine, they have a 3 to 4 times fracture risk. So these are easy markers to bring down. And I think that's what I really want to push tonight, in this interview, because it's laboratory tests. You don't wait for bone densities every 2 years. You look at labs, you can do them every 4 to 6 months, and you say, okay, yep, I've just decreased this person's HSCRP, I've just decreased their homocysteine, I've just improved their NLR ratio, their neutrophil lymphocyte ratio, I've done all these things. I know I'm on the right track, and then that what you're doing is helping.
Healthcare providers have trusted Dutch for years to discover the root cause of hormone-related issues with actionable results backed by peer-reviewed and validated research. New research in the November edition of the journal Menopause now shows that dried urine testing is also effective for monitoring hormone replacement therapy. This exciting new study is one of the many validated papers Dutch relies on to help providers navigate tough treatment decisions with confidence. Learn more about Dutch testing and our commitment to following the science at dutchtest.com/research.
Hey there, listeners. It's your host, Dr. Kara Fitzgerald. I have a question for you. How much time do you spend ordering functional lab tests for your patients? I bet it's a lot. Ordering from multiple lab companies for hundreds of patients can quickly turn into hours of admin time. But there's a new way to order lab tests I'm excited to share with you. Rupa Health is a tool that lets you order from over 30 specialty labs in a single portal. You can order all the tests you normally do from companies like Dutch, Vibrant, Genova, and Great Plains, and so many more. Imagine you're ordering a hormone panel for a patient that includes tests from 3 different labs. You have to log onto 3 different websites, place separate orders, come back weeks later to check on tracking numbers, download results, et cetera, et cetera. Rupa eliminates all of that by having all ordering, tracking, results in a single place, and they also handle invoicing, tracking shipments, automated follow-ups, personalized instructions for completing tests, and much more. The best part about Rupa is that it is free for you. Go to rupahealth.com, that's RUPA health.com, and join a live demo or sign up to see how it works. Now let's get back to today's show.
What else do? I do, a lot of times I do a DHEAS. In women, I'm thinking maybe doing estrogen. I definitely get a sensitive estradiol on them. Pretty much everybody with a lot of bone density loss, I get a gluten panel. I get anti-tissue transglutaminase IgA, total IgA, anti-gliadin antibodies IgG and IgA. I get those on most everybody. What else do I get? Vitamin D, of course. I like it to be at minimum at 35, but probably 40 to 60 nanograms per ml. I don't push for 70, 80. I don't think that's helpful. And I think that's about, I do serum protein electrophoresis and people I'm a little bit worried about, a little bit older, and you always get that. And that's about it. But then from those, I look for things like, does this person have parathyroid issue? And let's just address that one because that's kind of like a big deal. I probably see a parathyroid person every week.
Okay.
Very common. And it's often the person that is at 10.0 on their total serum calcium and their PTH is at 52, which both of those are normal numbers. The reference range for PTH is, I think, 15 to 63 usually, depending on the reference range. So 52, 55, the clinician that they're seeing says, hey, everything's fine. 10.0, 10.1, that's fine. But it's not fine a lot of times. And as you know, PTH and serum calcium can go up and down depending on the day. So yeah. I do lots of serum calcium and PTHs. There are a lot of parathyroid people out there that aren't being identified, and that will decrease their bone density for sure. So really got to figure that out. The 24-hour urine calcium, same thing. There's a lot of people who, number one, are losing serum calcium in their urine and aren't identified. And then there's a whole other group of people that are on hydrochlorothiazide by their physician because they did a 24-hour urine calcium when they were taking supplemental calcium. And now, they're taking supplemental calcium during the collection of urine. And so they have a 400. So it looks like they have hypercalciuria, and they don't. They were just taking the supplement.
Or they could be drinking a fortified plant milk, right? I mean, they're like the fortification is so rampant.
That's right.
We're probably unwittingly, consuming.
Now they're identified as a hypercalciuria person and put on. I've seen many of those.
Wow.
But I guess.
And the SPEP, can you just circle back to that? The serum protein electrophoresis.
I'm just trying to rule out MGUS, and MGUS doesn't necessarily lead to bone loss, but it's certainly something you have to be aware of for multiple myeloma. So, and I see that sometimes. I probably had 4 cases of that. So I want to make sure I'm not missing
it. Yeah.
Every single case of osteoporosis doesn't mean it's osteoporosis. It could be something else causing bone loss. And that's the issue you really have to be so aware of. Person comes in with osteoporosis, You got to rule out everything. You know, it can be something else. I've had 3 patients now with hypophosphatasia. I mean, I remember, you know, reading, oh, you'll never see hyperphosphatation. I do. Ehlers-Danlos syndrome. You'll never see that. Yep, I've seen it, you know. So there's a lot of different things out there that has bone loss. And
Do you cover that in the book? Things that you want to rule out? You do. Yeah. So people, you can, physicians, clinicians, you know, and, you know, just the consumers listening to this podcast. Yeah. You just, the book is such a treasure for these less common, but potential issues.
Potential issues that are not that uncommon. And but what I'm, you know, I want people to know that you can use these laboratory tests as therapeutic targets. They can identify things that we're going to say, okay, this is off. I'm going to fix it. I'm going to address something and fix it. Because then you can use that nutritional input to say, I'm going to get that homocysteine down. I'm going to improve that whatever, you know, and then you see it improve. You go, oh, right, I'm on the right track here.
Well, and yeah, and your patient is really excited about it. Okay, so let's go back to this person who's not going on meds, but they've got a pretty aggressive osteoporosis. You're going to start them on a nutrition protocol. What does that look like?
Well, first, if they have a gluten issue, obviously they're gluten-free.
How often do you find that? And how do you diagnose gluten sensitivity versus celiac?
Well, I guess I look at anti-tissue transglutaminase, and if it says it's celiac, it's celiac. You know, if it's above 20 or so, they're probably celiac, 20, 25, something like that. If that's at 2 and their anti-gliadin antibodies are 30, then sensitivity. They're still coming off of gluten. I don't care if their anti-tissue transglutaminase is at 2 and their gliadin antibodies are 15, 12, they're still coming off of gluten. Gluten causes bone loss, not just from a disruption of the endocytes of the villi in the gut, so decreased absorption, but it also causes bone loss because anything that ramps up the immune system is going to ramp up the osteoclasts, because the osteoclasts are a form of a white blood cell. They are derived from the hematopoietic stem cells, the same as the white blood cells are. So you get on the macrophage monocyte cell line from the hematopoietic stem cells is the osteoclast. Well, same as the white blood cells. So the white blood cells talk to each other through pro-inflammatory cytokines, interleukin 1, interleukin 6, tumor necrosis factor, interleukin 17. Every time they talk to each other with those cytokines, the osteoclasts are listening. They're saying,
Sure.
There's something going on.
Information for me.
I'm all excited. And the only thing I know what to do is eat things, and I eat anything, and that's bone. So
just like macrophage. It's like a macrophage. Yeah.
Well,
munching a bone specific macrophage.
I think, you know, if people wanted to know one thing they came away with on this, that's what I would say. Look what a macrophage does. Look what an osteoclast does. They're both eating things, and they're both related, and they both same exact language. So anything those macrophages, you know, dysbiosis, your gut, you're going to.
Well, this circles back to your original point about everybody being vulnerable for osteoporosis or for bone loss to one extent or another. I mean, because everybody's struggling. The inflammation is de rigueur, you know, certainly in this country and, you know, around the world. And you know, and unfortunately, just as we age, unless we're really mindful of it, you know, if we're really intentionally living, inflammation will increase, and that correlates with bone loss.
That's why I like estrogen too, because estrogen is an immune system modulator. It calms down the immune system, but it's also helps with mechanotransduction. So for example, you know, the reason why atherosclerosis and osteoporosis are related is because angiogenesis and osteoporosis are related, because you get poor capillary health and you get a poor endothelial glycocalyx. You're going to have the same, there's the same system in bones. You have a glycocalyx in the dendritic connections between osteoclasts and between osteocytes. And if those just the same as in the endothelium in the vascular system, if that glycocalyx is degraded, you're probably going to have a degraded glycocalyx in the same dendritic system in the osteocytes. And now they're not going to be able to talk to each other. And they're not going to be able to talk to the osteoblasts. So the mechanotransduction, so you can exercise all you want, but that mechanotransduction is not going to get the message to the osteoblast, and the person's not going to have osteoblastic activity from the exercise they do. So looking at a person's vascular system health is another way to go.
And what do you do? What would you recommend for imaging?
Well, for imaging, for imaging, I don't, because I don't really do that, but I would do laboratory tests. Let's say a person has a discordance on a hip. Let's say their left hip is a negative 2.8 and their right hip's a negative 3.4 neck. It's a little weird. Maybe they're having a vascular issue. Maybe the vascular issue is causing the discordance.
Right.
So I might do an ADMA or doing the different things we can do for nitric oxide, looking at the triglyceride, HDL.
Interesting. Fascinating. Wow. Okay. So ADMA, asymmetric dimethylarginine, and then looking at a lipid, sort of a complex lipid panel. So you get an idea what's happening in that arena that could be actually influencing the hip differential.
And if they have, a liver issue, they might have fatty liver. I mean, fatty liver is just rampant now.
Yeah, very common.
That might be an issue that, 70% of the liver blood flow is gathered from the gut. So you have dysbiosis, that's going to screw up that. You have fatty liver, that's going to, screw up red blood cell production, things like that. So all these things are connected. And I keep getting away from your.
I know from my original question, but it's really interesting. It's funny, Keith. We used to do this all the time when I talk to you in the lab. This is very familiar, but it's really interesting. All right. Well, I have to ask you a question in this arena. Like I have, thinking about the endothelial glycocalyx and the bone glycocalyx, like, there's some cool seaweed products out on the market now for the endothelial glycocalyx. Would you consider that in a bone intervention?
Definitely would, and also with the gamma and delta tocotrienols. But yes, that seaweed, I can't remember what it's called.
Yeah, arterisol is one of them. But yeah,
and any of these nitric oxide boosters, are going to pomegranate.
Fascinating. Yeah. All right, so let's go back to our patient. Okay, so we know it's really interesting. I know other people are into it, but yeah, let's walk through putting together a protocol.
All I got to was decreasing their gluten.
Their gluten. We're taking them off gluten.
That's all I got to. But I would make sure that they're getting vitamin D, because vitamin D is going back to the basics, making sure they get D, the magnesium, vitamin K. What does vitamin K do? It carboxylates or activates the osteocalcin. And what's osteocalcin? It's produced by your bone cells. It's a protein that essentially is a nucleator for the hydroxyapatite crystal. And you must activate that for the crystal to form. So I usually say 500, 700 micrograms of K2MK4, 50 to 100 micrograms K2MK7, probably 500 to 1,000 with K1. If you do that, there's enough carboxylation of the osteocalcin going on. So that's awesome. Protein is huge. As people get older, they do not eat enough protein. So, was it 1.2 grams per kilograms or something like that? But
even more, yeah.
I usually say at least 70 grams a day. And
what type?
I like hemp protein, pea protein, whey protein. Hemp's a really good one. But, just regular food too, sardines, great.
Salmon.
Shrimp, fish, salmon, so yeah.
Do you stay away from animal protein for any reason, or you don't consume it? Are you I think you might be vegetarian, are you?
I eat roadkill, Karen.
Oh, you eat you eat anything. Oh, yeah, you eat roadkill. That's your secret. That's your secret to succeeding at those triathlons. You're out there like chowing on the roadkill.
No, I don't eat. I said don't eat. I
A
can't.
possum.
I can't remember the last time I had beef. I don't eat pork. I don't eat beef. I don't recommend them. But no, fish, chicken's fine. Shrimp.
Okay, so we're increasing the protein. We're pulling them off of gluten.
Salt is a big deal. I have so many patients who come in, they're very proud that they're on a low salt diet. That's not good. If a person's too low on salt, that's detrimental to bone too. You need some salt, but obviously too much salt increases the release of calcium in the urine. So I look at that, the sodium level in their CMP, make sure that that's okay.
And where do you like to see it? Just within what?
Range, but if it's below 134, that's an issue.
Yeah.
So,
Okay. What about potassium on a CMP? What's a good potassium for you?
I guess I don't look, well, I just make sure it's in the reference range. I don't look to see if it's high or low. If it is high or low, then that's an issue. But what I do look at is a person's first morning urine. And if that's a 5.5 all the time, then I boost them up and I say, listen, I haven't taken electrolytes. I have this product called Osteomineral Whey, and it's the mineral part of goat whey. So they
Wow.
goat milk and they get a gallon of minerals, and it's great alkalinizer. It's not very high in magnesium, but it's high in calcium, potassium, and bioorganic sodium. So it's really it's really alkalinizing, and I have them take that every day. And if that doesn't improve, besides their increase in vegetables, green leafy vegetables and stuff, then I have them take potassium citrate or bicarbonate.
Okay. And I will link on your website. I was going to bring this up after we moved through the protocol, but Dr. McCormick has a beautiful line of supplements. And I know some of the protocols you're leaning on your products, Osteo Naturals. And we'll again, we'll pop it in the show notes, but okay. So
yeah, so I just make sure that like I said, if their pH is really low, I want to get up to 6.5. And then, so the potassium really helps to do that.
And you're measuring pH how?
Just for the urine.
Okay.
So there's a hydration membrane around bone. And so all day long, people are breaking down their tissues. And at night, they go into repair, and a lot of hydrogen is produced, the acidic hydrogen ions. And so you need to buffer those hydrogen ions. And there are your 4 minerals is, besides breathing that does it, getting rid of the carbon dioxide, magnesium, potassium, sodium, and calcium. Those are alkalinizing minerals. So there's a hydration membrane filled with the sodium and potassium that surrounds our bones. That's actively tapped by your body to buffer those hydrogen ions. But if that hydration membrane is not replete with potassium and sodium, we go to the parathyroid hormones, parathormones release that stimulates the osteoclast to break down bone, to mine the calcium, magnesium, to buffer the pH.
Wow, interesting.
So make sure that does not happen.
Right.
And I'm not saying urine calcium is the best way to do it. It's the only way I kind of know what to do, and it's not perfect, but at least it's something that helps.
Do you recommend people start their day with some electrolytes then?
Not necessarily start their day, but for sure, taking electrolytes, trace minerals, and but yeah, I think electrolytes are very helpful, trace minerals.
So this person again has pretty severe osteoporosis. What are going to be some of the workhorse nutraceuticals you're prescribing, and how do you dose them?
If they have,
and what type of calcium, if you're going to use calcium? Yeah, go ahead.
Yes, I don't care on calcium, but I don't like calcium carbonate, calcium malate chelate, calcium bisglycinate, calcium citrate. They're all fine. Calcium tartrate. If they have a high CTX, I for sure put them on resveratrol, quercetin, at least 200 milligrams of each. alpha lipoic acid 300 milligrams, berberine 300. N-acetylcysteine is great for helping the estrogen work, for antioxidant. And that's what we're trying to do. We're trying to bring down the oxidative stress, because that's what's going to promote the osteoclast. But the alpha lipoic acid and cysteine berberine, those really, really help. Fish oil, really good way to go. Like I said, calcium, magnesium, I usually say 300-400 milligrams of magnesium, trace minerals. The calcium, I usually only do 500, 600, 700 milligrams of calcium max, because I want to get their calcium through their food. I want to, I sell a calcium supplement, but I often tell people, don't buy it. I want you to eat your sardines, I want you to eat your greens, and I want you to try to figure out how much you're taking. If you're getting 1,200 milligrams, then you don't have to take it. But if you're not, and a lot of people don't do any dairy at all, they're probably going to have to take it, because it is hard to get 1,200 with no dairy at all. But I push people for like kefir. Goat kefir is super, because people can eat goat much better than cow. Lots of minerals, lots of protein. It's lots of probiotics in there. Sauerkraut, kimchi, all those things are great for the gut. So gut health is so prime in improving the person. So that person we're talking about that has a negative 3.3, if they have poor gut health, I'm going to attack that gut health.
Well, wouldn't you say that's probably de rigueur, like poor gut health and osteoporosis? I would imagine most of, if not all of your patients.
Well, that's true. 90% of them,
yeah. And I just wanted to point out to the listeners who might, be thinking about the dosing. You're pretty modest with your dosing. Like, for instance, berberine is routinely prescribed these days at 1,500 milligrams, and you recommended 3, thinking about the mechanism for bone. Yeah, go ahead.
Yeah, because they talk to each other. The berberine helps the alpha lipoic acid do its job, and the taurine in there really works way better when you do it with these other things. So, and these people are going to be on it for long term. I don't want somebody on berberine 1,500 milligrams for years, So it's okay to do berberine that long if you're working on a gut issue, but we're going to work on that gut issue in other ways besides the berberine, probably. So they're on that for a while. So yes, it is low dose stuff.
And that's always been your approach. What else do I want to ask? And lifestyle interventions for this patient? What kind of exercise are you going to prescribe? Are you going to prescribe, vibration plates, like the OsteoStrong protocol that some people are using as well? And so what are the lifestyle pieces in general, not just exercise?
The more exercise they do, the better. The more
what type?
The more times that they exercise is better. So you don't want a person exercising 3 days a week for an hour and a half each time. I want them to exercise 6 days a week, for 30 minutes. And regular walking doesn't cut it. Either really brisk walking, but also you have to do weights and squats and split squats and regular squats, but making sure that back is protected, because you put too much weight on that person and they really can break. But light weights, I really always advocate that people hook up with a PT or trainer, because it is so easy. And there's nothing worse than being all excited and wanting to do exercise to help your bones, and then a week later you break something because you didn't know what you're doing. So flexion is dangerous. Extension is a good way to protect yourself. So anytime you flex and twist or just flex that spine, you're putting a tremendous amount of pressure on the anterior part of the vertebra, and that's how you're going to get a wedge fracture. But yeah, progressive resistance and high intensity training helps, but only under the guidance of somebody who's watching the way you're bending and stuff.
Yep.
Vibration plates, I think, have their place. They do not take over the place of exercise. It's a vibration plate is in addition to exercise. And the more you stimulate those osteocytes to stimulate the osteoblasts, the better it is. That vibration helps, but we also have to make sure that that endocalyx and that glycocalyx is healthy. You're not going to get anything out of this. So it's I always think of exercise as a two-phase thing, making sure that that person has good glycocalyx ability, that they're a good ability for the osteocytes to make that mechanotransduction. And that's one of the reasons why I push for estrogen a lot of times, because estrogen helps improve that mechanotransduction. So that stimulus of the exercise to the osteoblast to build bone. Estrogen helps that. And doing a low dose estrogen is not dangerous. Bioidentical low dose estrogen with a patch or cream, and making sure that an estradiol level only has to be 20 to 30 picograms per ml to do its job as far as maintaining bone density. You're not going to really improve bone density with the estrogen, but you're going to help maintain it.
Awesome. That's great. What about testosterone?
Yeah, I don't
You use DHEA, but yeah, go ahead.
use DHEA, but I don't use the testosterone, and the reason why is because I think that's just changed into the estrogen. Estrogen is where it's at. So I think there was a push like 10 years ago for testosterone. I don't see that as much. I've never seen it promoted in the literature that much. So I don't think it helps.
Mm-hmm. And years ago, when we talked, you were not interested in high dose K2, as was used in, I think, a couple Japanese studies. And you actually said that I think it had the potential to suppress testosterone.
That's right, because you need undercarboxylated osteocalcin for testosterone production, for insulin production in the pancreas, for other things in the body. And so when you do too much vitamin K, it's too logical, and I think you can mess up other things. You need a balance between the carboxylated and the undercarboxylated osteocalcium.
So fascinating. Like many things exist in that U curve, the sweet spot you want at the bottom of the U, not too little, not too much. What about, you talk about cortisol in your book in a variety of ways, the stress response, even in inherited. What about, yoga, meditation? I mean, what are some of the lifestyle things that you think are essential for bone health?
Definitely. I mean, cortisol increases, DHA decreases, cortisol increases, and estrogen, testosterone decrease. So sure, that's a big part of this. And any stress, whether it's physical or emotional stress, is going to hurt your bones. Nothing worse than cortisol for boosting osteoclastic activity. It definitely does a great job in that, and hurts your osteoblasts and hurts osteocytes, increases osteocyte death. So all those are important lifestyle changes for sure.
What about toxins? What about persistent organic pollutants? What about, eating organic, avoiding glyphosate, et cetera, et cetera? What about, metals, obviously lead.
Endocrine disruptors are big. Decrease in, so I really push organic foods, and even where a person lives, they do have to kind of, that's a hard thing to change, obviously. You do have to be aware of that kind of thing. And but the best we can do most time is organic foods. And when you go for your run, you don't go run by the freeway.
It's remarkable how many people do. I mean, it's really remarkable. And
I ride bikes all the time, so I'm in the traffic all the time, but I try to ride on, low traffic roads, not so I don't get run over, but so I don't breathe this stuff too.
Yeah, of course. We've covered a lot, and I know everybody will get your book. I think I don't know. We're I guess we're really wrapping up here. I mean, I think that ultimately there's a lot of hope in your message. I mean, even if you need meds, it's going to be for a finite period, and you're going to do all of the underlying work that you outline. And
Right.
people can get better, and you're a testament. Like, you can get better and get on with your life, and you can go do Ironman. Some people, probably not all, but
No,
most people.
you're right. The medication business, the medications are not bad. They're just
Yeah.
bad use. And they're used long-term by a lot of physicians, and they're not addressing the other parts about the person's body. They're not addressing their liver health, their vascular health, their just overall health, their protein intake, their nutrition intake. They're not addressing that. They just do the drugs, and they leave them on them for long term. Well, that's not what should happen. But doing the medications short term, if they're necessary, they're okay to do it. But am I a big proponent of drug therapy? No. But I am a proponent of using them when we have to get a person emergency medicine, getting them out of that hole so they're not going to fracture. And then we keep them out of the hole with doing the right things that we're going to do nutritionally and exercise wise and in that way. But
That's awesome.
and we do this all by looking at therapeutic targets. We do all these lab tests. We look for things we can fix, and we attack those things in the way, most of the listeners, are going to know how to do,
Yeah.
and
Yeah.
they don't have to know specifically about osteoporosis. And that's what the beauty of this whole thing is. Everybody knows how to look at it as CBC and fix things on the CBC, fix things as CMP. Well, when you fix those things, you're going to help work on their bone health.
Absolutely. Yes. And we're good in functional medicine at dealing with underlying inflammation and gut health, et cetera, et cetera. So yeah, it makes sense that you're going to be, addressing bone health with all of those foundational functional interventions. There's a lot more that you cover in the book. The book is, again, 700 pages long, folks. So there's many supplements we didn't cover today. And I know some of you are wishing that we had talked about, strontium or boron or some of the other things, and we could go on and on about them, or biotin. But do grab the book. It's $40. It's going for $39.95. And this is a reference that you'll use for years and years to come. How are you today? I mean, how is bone health for you, and how carefully do you monitor it?
I started off a negative 4.5. I'm a negative 3.3 now, and I've been a negative 3.3 for 20 years.
But your trabecular strength must be pretty fabulous.
The truth, I've never had a TBS done.
You got to get it done.
There's no TBS out in Western Mass that I know of.
Right. Well, and clearly you're doing pretty well. You're not fracturing.
But no, I've never done a TBS, and I would like to, but I just stay at negative 3.3. And I think everybody says it's natural to lose bone density. And I used to always believe that, and I used to always say that, but I'm not sure that's true anymore. Because I'm not losing bone density. I've kind of stayed the same. I was a negative 3.3 15 years ago, and I'm still a negative 3.3.
That would scare some people, and to be a negative 3.3, that would scare some people and hold them back from living as fully as you are. What would you say to that?
Well, I think if you've been at a negative 4.5, then
you're rocking.
I'm rocking. That's right.
Yeah.
And, my CTX used to be really, really high. So a person with a negative 3.3 with a normal CTX, that's
no worries.
Usually. But a negative 3.3 with a 800 CTX, that's a worry. So CTX can be used not just to say that person's losing bone density, but it's going to also be used to say they have a high fracture risk. So that CTX is directly related.
It's essential. Yeah, and it's easy to do. Well, listen, Dr. McCormick, it was really great to talk to you today. It was fun tour de force in looking at all things All Things Bone Health. I really appreciate you coming on. I wish the best success to you. And well, and you're already out there in the world doing it, treating people around the world. I know you consult with folks around the world. So we'll link to everything in the show notes, folks. So just head over there and definitely buy his book. And I think you,
very much. Thanks a lot.
absolutely, absolutely.
As always, thank you for listening to New Frontiers in Functional Medicine, where because of my sponsors, I am able to bring you the best minds in functional medicine. And of course, today is no exception. Not everybody can be a sponsor on my platform, so I appreciate the good work, the relentless research, and the generous support from my friends at Rupa Health, Biotics Research, and Integrative Therapeutics. These are brands I know and trust in my own clinic, and I can confidently recommend them to you. Visit them at rupahealth.com, bioticsresearch.com, and integrativepro.com. And please let them know that you learned about them on New Frontiers. And if it's not too much to ask, I would really appreciate a thumbs up or a kind review wherever you're listening to New Frontiers. Thanks.